macrophage make endothelial cell proliferations and make angiogenesis, and then to lead the hepatomegaly syndromes. And NO make the vasodilatations and due to the hepatomegaly syndrome too. In the other hand, that systemic inflammation, recruitment of macrophage in the lungs, and increased expression of activity of enos and hence oxygenation, it is increased release of nitric oxide and carbon monoxide, and it could be make the vasodilator too. So it is make the hepatomegaly syndrome. Yeah, I think it is 2012. Some pathogenetic will have some study with CBDL. It is common bile duct ligation in animal model with cirrhotic. They ligated the common bile duct and then produce some secretin like endothelial-1, and they have bacterial translocation, endotoxin, then add bile acid and others, and then they make intrapomular dilatation. It is a group of intravascular monocyte accumulation, and they will group that angiogenesis. Pulmonary vasodilation is triggered by excessive nitric oxide production through endothelial 1 and NTB receptor driven of enos. It is in 2002 relation hem exogenation by nitric oxide during hepatomegaly syndromes that in 2 weeks that we found that they are all pressure oxygen MAP it is increased, but in 5 weeks it must increase than 2 weeks before. Increase 14-fold by 5 weeks. And then hemoxygenatin 1 expression is increased after ligation of common bile duct, and then secretion of monoxide is increased after CBDL, and hemoxygenatin activity contribute to blunted HVR. And NOS inhibition block of hemoxygenation induction and lower of monoxide hemoglobin level in CBD ligation rate. It is the role of endothelin-1 and endothelin-B receptor in pathogenesis of hepatomegaly syndrome in the rat. It is by Ling et al. In 2004. It is physiology alteration hepatomegaly syndrome after CBD ligations that we found that alteration in circulating endothelial mediators and hepatomegaly after CBDL. It seemed like the study before. Now I want to talk about clinical picture of hepatomegaly syndromes. The clinical picture of hepatomegaly syndrome can be asymptomatic patient and with symptomatic. Symptomatic patient can be with bradyapnea, orthorexia, orthopnea, cyanosis, static spider nephri, digital clubbing, and spider angiomas. It is the pathognomonic for hepatomegaly syndrome. It is when the patient from the supine position to sitting position, the oxygen is down, and the patient will, the AA2 or partial oxygen pressure is decreased. We call that it is bradyapnea or orthorexia. In the clinical picture of hepatomegaly syndrome restrictive patient, Amir et al. Conclusion that the clubbing is positive rate of value of 75%, and dyspnea with negative reduction value of 70% of the best clinical factor of diagnosis hepatomegaly syndromes. It is the clubbing Then it is the characteristics and diagnostic failure of the sign and symptom in hepatopulmonary syndromes. We find that is that the clubbing, it is more specific in the others like cyanosis, dyspnea, palmaritime, or spider angioma. Yet the other palmaritoma, cyanosis, and spider angioma. And it is diagnosed failure of arterial blood gas in hepatopulmonary syndromes that we have the sensitivity of partial pressure or arterial gradient more than 30. It is the best failure. And the other one, it is orthodexia more than 10. It is very sensitive clinical pictures in diagnosis of hepatopulmonary syndromes. Chairman and ladies and gentlemen, it is my take-home message that hepatopulmonary is common finding in patients with cirrhotic that increase mortality, that hepatopulmonary syndrome is defined by liver disease, intrapulmonary vascular dilatations, and abnormal oxygenation. Hepatopulmonary syndrome should be considered in patients with liver disease and unexplained oxygen saturation of less than 96% or any a clinical finding like flatepnea, orthorexia, clubbing, or cyanosis. Thank you for your attention.
Questions at the end of session, yeah? Okay.
Yeah, I invite the next speaker, Dr. Cynthia Murthy. It is from Indonesia. The title is Update on Medical Treatment for Hepatopulmonary Syndrome. Time is yours.
Thank you. Good afternoon, ladies and gentlemen. It is my honor to be here in this APASL meeting. My title is Update on Medical Treatment for the Hepatopulmonary Syndrome or HPS. This is my disclosure. My outline is, first I will talk about the pathophysiology of HPS briefly, and then the medical treatment, and if I have a bit time, I will talk about the non-medical treatment, but the liver transplant will be given by the next speaker. So as we know, hepatopulmonary syndrome is a common problem in cirrhotic patients. It is an abnormality of pulmonal gas exchange caused by the intrapulmonal vascular dilatation. If we look at to this picture, we can see that both the dilatation of the vascular pulmonary and also the shunting arteriovenous will make the diffusion of oxygen to the red blood cell become not effective. So I will come to the pathophysiology of HPS briefly. So broadly, there are two events happen in the HPS. One is the vascular dilatation, and second is the angiogenesis. It's just to make or to simplify the pathophysiology of the HPS. The main agent play role in this event is nitric oxide and also the carbon monoxide. The other agent like the endothelin and then TNF alpha, VEGF and VEGFR, also the endotoxin, bacterial translocation, and monocyte accumulation also have a role in the developing of HPS. So HPS patient has a very poor prognosis and has to be treated. So far there are medical treatment and also non-medical treatment for, including the liver transplant for the HPS. Medical treatment has targeted several points in the pathogenesis of HPS. That is nitric oxide, endothelin, angiogenesis, and bacterial translocation. So all agents that has effect on those 4 points has put into the trial to see whether it can treat HPS or not. Studies in medical treatment for HPS, most are used arterial pressure, oxygen pressure, and alveolar arterial oxygen gradient, and also the oxygen saturation as a target outcome. And actually, there are so many agents has been put on the studies, but most of them didn't show any benefit. So it is impossible to show all the agents on this presentation. I will show only several agents that still mentioned in the journal until now. That is the pentoxifylline, mecophenolate, mofetil, methylene blue, L-name, sorafenib, norfloxacin, and garlic. So this is one of resume of all medical treatment that has been done. If we look at this picture, we can see that most of the trial has a very small participant, less than 20. This is also, you can see only 2 studies has more than 20 participants. And if we look at carefully on the outcome, we can see that even in the same agent, the result or the outcome still different or inconsistent between one to another trial. So I will start with pentoxifylline. Pentoxifylline is a non-specific phosphodiesterase inhibitor. So the benefit of this drug mainly because its inhibitory effect on the inducible nitric oxide synthase and also endothelin and TNF-alpha. It is mentioned also that this pentoxifylline has a downregulate action in angiogenesis. In the animal models, pentoxifylline shows benefit to reduce the vasodilatation. But in the human trial, there are 2 trials that give improvement in AaO2 and PO2. But the other trial shows no improvement, so still inconsistent result. And if we look at this trial, one trial from the 10 children with HPS, we can see that when the drug was stopped, the benefit will disappear. Means that the drug has to be given in the long term. This will make a problem because a lot of participants cannot tolerate the side effect of the pentoxifylline. And second is mecophenolate mofetil or MMF. So MMF is actually an immunosuppressive agent. It has ability to inhibit interferon gamma, TNF, nitric oxide, and also endothelin. And it also has the anti-angiogenesis by inhibit the endothelial and fibroblast proliferation. It is mentioned that it improves PO2 and AaO2 and also decrease the percentage of shunting intrapulmonary. And when the drug stopped, it is said that there is a long-term cure on the patient. Unfortunately, this report come only from one case. So only one case report, but even though only one case report, it is mentioned that these drugs, MMF, is worth to try to put into a bigger trial or study. The third is the methylene blue. It is a contrast agent for diagnostic purpose. It prevents vasodilatation by inhibit the activation of guanylate cyclase, and it improves the PO2 and AaO2. But the problem is methylene blue has a very short action. If we look at this data, we can see that in the 10 hours after this drug injected, the PO2 start to decrease, then AaO2 also start to increase. Means that it's not feasible to be given. Yeah, so it's difficult. And the fourth is the antagonist of nitric oxide. It's L-nitroarginine methyl ester. There are 2 trials on this agent, and both shows the inconsistent result. And now it is shown that LNAME slowly actually release nitric oxide from its nitro group. And this is one of the drawback on its nitric oxide lowering effect. So maybe it's one of the cause why the trial outcome is inconsistent. The next agent is the sorafenib. Sorafenib actually is an anti-angiogenesis agent. It has ability to inhibit the VEGF, VEGFR, and also the AKT protein expression. On the animal models, it shows that it improves AAO2 and decrease VGEF. But in human trial, it failed to show any benefit. Sorafenib has been put into RCT on 28 cirrhosis HPS patient. Like this, 12 in the placebo group and 16 in the sorafenib group. And in the end, almost all can finish the study. If we look at the graphic, we can see that the red line is in the sorafenib group. The change in RRO2 actually is higher in the sorafenib group compared with the placebo, but the difference is not significant. So even the sorafenib significantly reduced the VEGFR 1, 2, 3 compared with the placebo. It doesn't show any significant difference in RRO2. This failure may be because of the dose are too low or the time for evaluation is too short or loss of the patient during the trial. But the other problem is if they increase the dose, then the side effect of sorafenib mostly cannot tolerate by a lot of participants, same like the pentoxifylline. Next agent is norfloxacin. So this agent intended to reduce gut bacterial translocation. Hopefully it can reduce the endotoxemia. There is one success case report using this norfloxacin. But when it is followed by the pilot study using 9 cirrhosis HPS patients, it shows no improvement in the AAO2. I will mention there are other agents that is not targeted on those 4 things, nitric oxide, endothelial angiogenesis, and also bacterial translocation. I cannot mention all in this presentation. I will mention only 2 that to me is very important. First is the oxygen. Administration of supplemental oxygen to maintain oxygen saturation more than 88% is very important to relieve the symptom and to prevent an organ damage. There are 2 cases had been reported to improve after a year oxygen treatment. There are 2 cases of HPS which is improved after 1 year therapy oxygen. Of course, because this is only a case report, we have to be careful in interpreting the result of this report. But it just wants to show you that the oxygen is very important for the liver function and liver regeneration. So it must be a part of medical treatment of HPS patient. And the other is the garlic powder. The exact mechanism on how garlic improves HPS is still unknown. Yep. Possible because garlic redistributes the pulmonary blood flow to apical and mid part of the lung. And it is also mentioned that maybe garlic has an anti-angiogenesis property. Garlic also already put into the RCT study with 42 cirrhosis HPS patient with a dose of 1 until 2 gram per meter square body surface per day for 8 until 18 months. If we look at the baseline, there is no significant difference between the group, treatment group and the placebo. And we come to the result. We can see here that the clinical sign of the HPS, like cyanosis and clubbing, is improved after the treatment. Even though in the placebo group it's also improved, but in the treatment group it is more. But let us look more detail on this part, which I give a box. We can see that the SO2, PO2, and AaO2 are improved significantly from the treatment group compared with the placebo group. Start on the 9th month of the treatment. This study also tried to show that the treatment group has a better survival compared with the placebo group, even though the difference is not significantly. So I will resume on the medical treatment or on HPS. Most trials in medical treatment on the HPS issue has a background, like has a small number of participants and not a randomized control trial, more case report, and has an inconsistent result. And they failed to show any benefit in human, unlike what they found in the animal models. There are two agents that has been put on the RCT. One is sorafenib and the other is garlic. But the sorafenib failed to show any benefit in human, and the second garlic, it's have a promising result. And so actually all agents in the medical treatment need further research, like bigger dose, longer time, better study design. But in the other hand, we have to also think about the side effect of the agent and also whether it can last for a long time, the benefit of the agent. So I will come to the non-medical treatment. It's about the transjugular intrahepatic portosystemic shunt or TIPS. There are two studies about these TIPS. One is the retrospective study on 81 cirrhosis patients, and the other is the systematic review on 10 studies. But because most of the studies are case report, then it's only consists of 12 cirrhosis patients. It shows that there are some improvement in PO2, SO2, and AaO2 after TIPS procedure. Some means not all have an improvement, and this improvement is not permanent. After some times, all the benefit will start to disappear. And the TIPS technique has influence on the response of PO2, SO2, and AaO2. There are several techniques of TIPS, and each technique shows a different benefit of the resolve of HPS. So in my conclusion, HPS is a progressive disease with a poor prognosis. Many agents has been put on the trial for HPS, but still no consistent result comes out. Only garlic powder have a RCT trial and give a consistent result from the trial. And non-medical treatment like TIPS sometimes works, but still liver transplant is the best option. Thank you.
Thank you, Dr. Sinta. And the next speaker, Dr. Vincent Ho from Australia. The impact of liver transplantation in the patients with hepatopulmonary syndrome, please.
Okay, thank you. And look, I'm pleased to follow two really good talks by Dr. Liragar and by Dr. Murty. It's made my job a lot easier. So my talk is on the impact of liver transplantation in patients with hepatopulmonary syndrome, or we'll call it HPS for short. So I first reviewed this topic over 10 years ago, and I'm pleased to say that some things have changed in the last 10 years, and some things haven't. But certainly in the area of liver transplantation, there has been quite some new developments which I think are important. Dr. Murty did mention about the importance of liver transplantation as a definitive option. And I will say that it is the only known effective treatment for HBS. What we know is that at least 85% of cases of patients with HBS that undergo liver transplantation will experience either significant improvement or complete resolution with their hypoxemia. Now, this resolution does take some time, and in some cases, it can be well over a year. So that suggests that something is going on in the process that it will need a year or so for the hypoxemia to normalize. And we'll talk about why that might be. So what we know, and this is a talk that Dr. Murty alluded to earlier about one of the particular therapies, LNAM. So we know that with humans, pulmonary nitric oxide overproduction, we can see that with exhaled nitric oxide levels has been found. And it's thought that if you've got pulmonary nitric oxide overproduction, that leads to microvasculature dilatation. There was one study that was done on 10 patients using an inhibitor of nitric oxide called LNAM. And what they found that despite reducing the levels of LNAM in the breath by exhalation, it doesn't actually improve gas exchange abnormalities, and it doesn't improve ventilation perfusion alterations. And the authors concluded that vascular remodeling, rather than nitric oxide dependent vasodilatation, was a more important cause of gas exchange abnormalities in HBS. And this is a really important point. It's not just pulmonary vascular tone. So these mediators are very important, but it's also something else which is going on, some sort of remodeling, architectural process which is happening. And as I said, I'm going to talk about this in more detail. We can refer to some animal experiments that have been done on HBS. This is a rat model for HBS that's been done. Typical bile duct ligation leads to liver cirrhosis, and we can see they get the typical HBS features: increased AA gradient, loss of hypoxic pulmonary vasoconstriction, and intrapulmonary shunting. So we know that one of the reasons why the pathology exists in HBS is out of an increased capillary size. So Dr. Lirigar referred earlier to the importance of radiolabeled macroalbumin aggregates. Now, they're about 20 to 50 micrometers in size, and they can pass quickly through the lungs. Now, we know that ordinarily, our normal pulmonary capillary diameter is less than 15 micrometers. It's anywhere from 8 to 10. So the fact that you've got these big aggregates, 20 to 50, going quickly through means that the pulmonary capillary has stretched, it's widened. And in fact, we know in HBS, it often has a diameter of about 150 micrometers, and in some cases, around the subpleural areas, it can be 500 micrometers. So in this rat model, they said that, well, look, there's either going to be widening directly of the pulmonary capillaries, or there's bypassing, some sort of shunting which is going on. We know shunting already exists, but this broadening, which is widening of the size of the pulmonary capillaries, was yet to be established. They did find in this animal model, rat model, that indeed the lung capillaries were dilated. They also found that there was an increase in the alveolar capillary density and some evidence for angiogenesis, which Dr. Lirigar referred earlier, that is part of the process, the pathophysiological process for HBS. Now with angiogenesis, and this is going back to this particular study, they showed some great electron microscopy images, and you can see here that big broad arrow on the left-hand image, that's a new blood vessel. So there's new formation of blood vessels. And on my left, you can see down below there, there is evidence of a spheroid cast. And that spheroid cast is really the beginning of new blood vessel formation. And indeed, what we think happens in HBS is there's chronic pulmonary overproduction of a number of vasoactive mediators, including nitric oxide, and in someone who's genetically susceptible, may result in variable combinations or alterations in the pulmonary vasculature, the architecture, as well as the tone. So it's also architecture and tone leading to that gas exchange abnormalities. And we can see here, this is a lovely image here, but if we look at the top left-hand corner here about hepatopulmonary syndrome, you need to have not only pulmonary vasodilatation, but also pulmonary angiogenesis. I mean, that is important. So the remodeling process which is going on here, it's angiogenesis, pulmonary vasodilatation, of course, the effects of these mediators. Now, what happens with liver transplantation? So, we know that with liver transplantation, there is going to be the correction of that vasodilatory, vasoconstrictive imbalance. So that imbalance is corrected. That constriction, we think, takes preferentially in relatively normal vessels rather than the abnormally dilated vessels, so that may lead to a temporary increase in shunt fraction, but later on, the abnormally dilated vessels then start to disappear, which explains why there's resolution of intrapulmonary shunting and hypoxemia. Now, the observation that the resolution of HBS after liver transplantation can take quite some time. It suggests that architectural alterations are at work. So not just pulmonary tone, but there is this architectural remodeling and vascular remodeling that's occurring. And it may be that the increased levels of nitric oxide that we're seeing could be a secondary phenomenon. Now, in this review of a cohort of 26 patients who underwent liver transplantation for HBS, they're actually followed up for a median period of 5.2 years. And what we found here was that the overall mortality was around 27%, with a perioperative mortality around 15%. The most common cause of death in these patients was severe sepsis. And they found that hypoxic respiratory failure was the most frequent postoperative complication, occurred in about 23% of patients. Now, the most important thing, and I've highlighted this in red here, if you can see that, the most important predictive factor for peri-transplant morbidity was a decreased DLCO. Now, I'm sure many of you know what DLC stands for. It stands for diffusion capacity for carbon monoxide. It is one of the most clinically valuable tests, we think, for lung function, because it measures the ability of the lungs to transfer gas from inhaled air to the red blood cells in your pulmonary capillaries. So here we've got what occurs in hepatopulmonary syndrome. Now, in cirrhosis, we find that mild arterial hypoxemia is often due to that ventilation-perfusion mismatch. So you can see what actually goes on quite clearly in the diagram. When you've got these, major intrapulmonary shunting and diffusion abnormalities, what happens here is that this can lead to, an increase in capillary diameter that prevents the oxygen molecules from diffusing to the center. So you can see top here, in a healthy alveolus, the red blood cells are moving fine, but down below, you can see that the capillaries are dilated. So remember that the oxygen is getting from the alveolus, it has to go to the alveolus to the center of the pulmonary capillaries. And when it's widened like this, it's not effectively getting the oxygen in to oxygenate the hemoglobin. And so what happens, therefore, is that distance, that capillary distance, becomes too wide. It's actually it's thought to be too great to allow for effective equilibration, you could say, of the carbon monoxide with hemoglobin. The other problem is that we know with cirrhosis, there is a very high cardiac output. And when you've got a very high cardiac output, that's actually going to reduce the capillary transit time, and therefore the amount of time which is to occur. But we also know that sustained low DLCO is often seen after transplantation in some cases of HPS. So we can see on the left-hand image here that in these 6 cases of HPS, after transplantation, their PaO2 levels increase back to normal. However, on the left diagram, on my left diagram over here, we can see that for a few of those patients, their DLCO levels, they aren't really improving in the long term. So you can see that, the PaO2 rises in the long term, but their DLCO doesn't. So that's very interesting. Now, why is that? Well, it's hypothesized that the low DLCO after liver transplantation may be due to structural pulmonary vascular changes that were already there before liver transplantation. So it could be due to the increased thickness of the walls of the small veins. And in fact, there was one case back in 1977, believe it or not. We think that case was a HPS case. But there was some great electron microscopy images that were taken, and you can see closer to me that there's an image here of a thick and small pulmonary vein in that patient with HPS, and we think that's due to this collagen interspersing with some fine filaments, whereas over there, further away, we can see that the walls of the capillaries are similarly thickened, and what this is doing is resulting in an increased blood gas distance and obviously contributing to the reduction in DLCO. So this was observed back in 1977. But we also know, and this is fascinating here, that when we look at a post-mortem study of 96 patients with cirrhosis, and there was evidence of thickening of the pulmonary capillaries in about a third of these patients. Now, to me, it seems quite unlikely that these changes are going to resolve very rapidly after liver transplantation. So this may be the reason why the DLCO remains very low despite an improvement in oxygen exchange. Now, the interesting thing about all of this is what we think or we conjecture to be the case, because after all this time, we still don't know exactly what happens to lungs of HPS patients after liver transplantation. I mean, in theory, this should be quite a relatively straightforward research study to uncover the resolution of these pathophysiological changes in HPS lungs. I thought, you could do a pre-transplant lung biopsy, followed by serial post-transplant lung biopsies over the course of a year, or just to make it 2 to be safe, and that way you could see what goes on. But this study has yet to be done, and so we don't know exactly what happens. But we suspect strongly that there is architectural remodeling that is occurring after liver transplantation. So going back to that study again, the same study that showed that a low DLCO was predictive of peri-transplant morbidity, it also showed that preoperative PaO2, which is that partial pressure of oxygen in the arterial blood, was shown to be a strong predictor. It was not shown to be a strong predictor of mortality. So in this particular study, it wasn't shown to be a strong predictor of mortality, but in many other studies that have been done, a low PaO2 was. So even back as far as 1984, severe hypoxemia was thought to be an absolute contraindication for liver transplantation. But we know from more recent data, and this is a study back in 2003 that was carried out in 2 centers, the University of Alabama at Birmingham and the Mayo Clinic, that severe hypoxemia was associated with poor liver transplant survival. We know that 24 patients that had cirrhosis and HPS that underwent liver transplantation over a 5-year period at these 2 centers, they were followed up for about a year after transplantation. They had preoperative evaluation for HPS that include measuring their PaO2 and their macroaggregated shunt fractions. And what they found was that the combination of a low preoperative PaO2 of less than 50 millimeters of mercury alone, or in combination with a macroaggregated albumin shunt fraction of more than 20%, were the strongest predictors of post-operative mortality. So that was back in 2003. Back then, it was quite clear at that stage that if you had severe hypoxemia, you wouldn't be doing well after liver transplantation. However, and I'll move to this now, we know that with HPS, it's got a poor prognosis. I believe this was mentioned by Dr. Liragar before, a 5-year survival of 23% without liver transplantation, as opposed to a 76% 5-year survival with liver transplantation. So in 2002, because recognizing that hypoxemia in HPS is progressive and mortality can be quite high, there was a stated exception policy that was established that was able to prioritize these patients for transplant. So if you had severe HPS, which we know with an arterial oxygen of less than 60 milliliters of mercury, they would be prioritized. And in fact, this is the exception criteria. So you had to have HPS and a PaO2 of less than 60 millimeters of mercury while breathing room air in the sitting position, not explained by primary pulmonary disease. So they didn't have any primary pulmonary disease. And they gave them a MELD starting point of 22 points, which is recognized as having a 3-month probability of death at 15%. And they actually increased their points every 3 months if the repeat PaO2 was lower than 60 milliliters of mercury, breathing room air in the sitting position. So this is the MELD exception criteria. Now, the European Respiratory Society Task Force recommends that liver transplant if your PaO2 is between 50 to 60, and considers it if your PaO2 is less than 50. So if it's less than 50, which is considered very severe HPS, as said, consider that on an individual basis. But as I said to you before, there was a reluctance for a long time to transplant people with very low PaO2 because it was recognized from the American data that they didn't do very well after transplantation. But with these very severe and severe hypoxemic HPS patients, we know that they have prolonged post-transplant hypoxemia and increased hospital length of stay. The reason why they could get post-operative hypoxemia, well, we know that after transplant, there's some changes that happen. Vascular mediators can come from the lung, enter the lung from the changes in the liver. We know that there's some remodeling that goes on, so that the vasoconstriction is probably affecting normal pulmonary vessels. And so that increase in flow could result in worsening of VQ mismatch. So these are reasons why you might have post-operative hypoxemia in HPS patients. But this study, which was a very important study that was done in the university, well, 2 hospitals actually, the University of Toronto and the University of Montreal, was a retrospective study of 21 patients with HPS that underwent liver transplant, and 12 patients who were diagnosed with HPS who didn't receive liver transplant. Now, what the researchers found was that there was a 100% peri-transplant and 6-month survival, and a 93% 1-year survival for liver transplant in HPS, which was really impressive. And the study was particularly important because it showed higher survival post-liver transplant in HPS and in severe HPS compared to prior reports. So certainly better data than the American data. And it was a landmark study, in my opinion, because it was able to identify patients with severe hypoxemia with HPS as having good survival, and by doing so, it actually drew attention to this group of patients from clinicians worldwide, and there was a renewed interest to look at considering these patients for liver transplantation. Now, this is another study that was done at the Mayo Clinic, and it was done in 106 HPS patients from 86 to 2010. And what they found was there was no evidence for increased post-liver transplant mortality in their subgroups based on PaO2. Really important. And they didn't find a post-liver transplant survival difference between HPS patients and a contemporary cohort of over 1,800 liver transplantations without HPS. They actually found a trend for improved post-liver transplant survival among HPS patients in the MELD exception criteria. Why is that? Well, it could be that advances in intensive care unit hospital protocols for managing end-stage liver disease, critical illness, hypoxemia, maybe they're some of the reasons why over the last 10 years we've seen considerable improvements in HPS survival, particularly for the hypoxemic patients. So, ironically, the issue now is that the survival of HPS patients with transplant has become so good, at least in the US. There's actually a lot of attention on whether the MELD exception criteria are unfairly advantaging HPS patients over non-HPS patients for liver transplantation. So this was a retrospective cohort analysis that was carried out on data that was submitted to the UNOS, very large database, I'll be finishing off very shortly. And they included 973 patients on the wait list that had received HPS exception points. I didn't find any association between wait list mortality and oxygenation, but they did find that pre-transplant hypoxemia to be associated with increased post-transplant mortality if your PaO2 was 44 millimeters of mercury or less. This is very important, and you can see that in that top graph here. PaO2 of 44 or less was associated with significant mortality, and they also found that overall mortality for HPS patients was significantly lower compared to others awaiting liver transplantation. So they feel that, look, if you've got a PaO2 of 44 millimeters of mercury, these patients don't do so well after liver transplantations, so you have to make the tough decisions. Perhaps, we can allocate that accordingly. So just to finish off with things, Eurotransplant experience has found that patients generally, there's really no difference between HPS and non-HPS patients. And coming takeaway messages: liver transplantation, only known effective treatment. We know that pulmonary and the architectural modeling is thought to be the main reason for the pulmonary changes after liver transplantation, rather than pulmonary vascular tone. And HPS patients fare well with MELD exception. Any change to the current rules is likely to be quite controversial. Thank you.
Thanks, Vincent. And the last, Professor Agayeva Gulnara from Azerbaijan State Medical University. His education certificate attendance in 2015 and metabolic changes for program of PhD, and 2019 is president of Abasal STG Delta hepatitis.
Dear colleagues, the topic of my presentation is personalizing care in patients with liver cirrhosis. Liver cirrhosis is the final result of chronic parenchymal distortion, cell loss, fibrosis band formation, nodule formation, and shrinkage of the liver, resulting in portal hypertension and deranged liver synthetic function. The annual global death due to liver cirrhosis is about 1 million patients. And viral hepatitis and hepatitis C and B, we hope that in 2030 we await the eradication of these diseases, but at the same time we await the peak of cirrhosis. And so the topic is very actual for this time. Liver cirrhosis could be reversible by appropriate treatment of underlying etiology, such as HBV, HCV, autoimmune diseases, and other etiologies. So evaluation and management of the etiology is the first and the most important measure for the improving of the quality of care in such patients. What we should do it in this situation? Consider in the compensated cirrhosis and specific complication as treatment of underlying cause if possible, treatment and prevention of varicose bleeding, treatment and prevention of ascites, spontaneous bacterial peritonitis, prevention hyponatremia, hepatorenal syndrome, hepatic encephalopathy, other complication, and evaluation for liver transplantation. The first and most of the other, among the other complications are ascites, and suggest quality indicators for management of liver cirrhosis is diagnostic paracentesis and requesting routine ascitic fluid tests, cell count, and differential total protein, albumin, and culture and sensitivity. Discontinuation of diuretic and fluid restriction in patients with ascites if serum sodium less than 120 micrograms. Prescribing empirical antibiotics within 6 hours in hospitalized patients within polymorphonuclear neutrophils more than 250 50 cells in millimeters in anesthetic fluid and prescribing long-term antibiotics in patients with first presentation of spontaneous bacterial peritonitis within 1 week of hospital discharge. In varicose bleeding, the main screening is esophagogastroduodenoscopy for varices in compensated and decompensated cirrhosis, receiving non-selective beta blockers or endoscopic varicella ligation in patients with negative history of varicose bleeding and medium or large varices in esophagogastroduodenoscopy. Starting somatostatin or its analogs in patients with cirrhosis and acute gastrointestinal bleeding within 12 hours presentation, and preventing the recurrence of bleeding with varicose ligation every 1-2 weeks until obliteration, beta blockers, or a combination of both. What about hepatic encephalopathy? At first, documenting the grade of hepatic encephalopathy in the chart and receiving oral disaccharides or rifaximin in patients with persistent hepatic encephalopathy. Liver transplantation indications and preventive care, vaccination in non-immune patients against HIV and HBV. And up to 40% of patients with liver cirrhosis suffer from one or more comorbid disease. These comorbid conditions usually affect the morbidity and mortality of these patients. The exact effects of comorbid disease on liver cirrhosis pathophysiology and the effect of cirrhosis on the course of comorbid disease need more evaluation. However, improvement of quality of care needs assessment of comorbid disease and their proper management. And as you see, conditions with more effect of mortality is obstructive pulmonary disease, acute myocardial infarction, peripheral arterial disease, epilepsy, heart failure, substance abuse, non-metastatic hematologic cancer, chronic kidney disease, metastatic cancer. And among other conditions, the HIV, diabetes with and without complication, obesity, cerebrovascular disease, and some psychiatric conditions. For improvement of the quality of care in patients with liver cirrhosis, a more holistic view is required. In addition to the management of the liver disease and its complication, per se, enough attention to care for comorbid disease and other risk factors should be considered. Special screening and preventive measures for cardiovascular diseases and neoplasm are required. This could be done by control of important risk factors such as smoking, high blood pressure, diabetes, and hyperlipidemia, and advising dietary and exercise program. The management decision for patients with liver cirrhosis should be individualized, multidisciplinary, and patient-centered. The key components for a good care for liver cirrhosis of patients: enhancing the patient's self-management capability, preparation of a multidisciplinary decision support system based on evidence-based recommendations, preparation of clinical informatics, including the baseline characteristics and new events, laboratory data, medications for proper decision-making, designing a support system for training hepatology nurses, possibility of home visits, multidisciplinary care, and possibility of continuous contacts with patients and their relatives. The healthcare team gives the sufficient knowledge to patients to be capable for evaluating and solving the usual day-to-day problems or reporting them to the healthcare team for solution. It is based on family, organizational, and community engagement and support for self-care and better management. Availability of educated nurses as coordinators, home visits, and preparation of informative brochures are useful actions in this model. A patient with ascites should learn to daily weight recorded compare it with the ideal weight, know how to use prescribed medications, and report unusual weight loss or excess. The patient is advised to call the nurse or doctor if she develops fever, abdominal pain, or difficulty with breathing. Sometimes an educated family member plays this role. And on this slide, you can see our liver cirrhosis team with coordinators, nurses, and doctors who are ready to answer to all questions by calls from our patients during 24 hours daily. On the left side is a questionnaire for conditions or complaints of patients on their visit to department. And on the right side, the paper for the schedule for filling by themselves for patients who fill the diuresis and drinking water or other liquid in acidic patients. And in the center, you can see the cases where we keep all the laboratory data, ultrasound investigation, MRI, and others. And so the regulation helps us to control the patients with liver cirrhosis and improve the care for such patients. And I know that this is the last presentation, so I made it shortly because all of you are tired, and I congratulate you with the great important event, Apostle Annual in Bali. Thank you for attention.
Thank you, Professor Agarefa Gunara, for your distinguished lecture. I invite for all the speakers to the stage, Dr. Vincent Ho and Dr. Sinta. It is time to answer question and answer. You have some question from the floor? Yeah, we have questions? No? Yeah, I want to ask some question to you, Vincent Ho, that it is the only treatment for hepatorenal syndrome is transplantation. But do you know that comparable from patient with cirrhotic with hepatorenal syndrome and not have, that it is high mortality for the with XPS. What is your opinion about to select the indication for transplant before that?
So we'll just turn this on. Yeah. Okay. So yeah, Dr. that's a great question. And again, I was touching base upon this at the very end. I'm not sure if I had time to really explain it, but based upon that retrospective analysis, it suggested that if you had a PaO2 of less than 44 millimeters of mercury, that was associated with a very bad outcome. Now, the Europeans would challenge that because they feel that based upon their data, they didn't really feel there was a difference. They didn't feel there was a benefit in terms of waiting list survival. So that time to transplantation, if there's a difference between HPS and non-HPS, which the Americans found, favored HPS. They didn't find that in their analysis. So, and they feel that if you start making arbitrary cutoffs, like 44, 46, what that's going to do is it's going to increase the waiting time for transplant for these patients. It disadvantages them. And that's why it's very difficult to do. At the moment, we've got the MELD exception criteria. It's well defined. Yes, it probably does, according to the American data, it probably does favor patients, HPS patients. But then again, we have to realize that their survival, their 5-year survival without transplant is abysmal, 23%. And so you have to balance the high mortality of waiting for transplant versus their improved survival after transplant. And I guess that is the key. And the Europeans seem to favor keeping it as it is, which I'm also kind of in favor as well. I think it's controversial. Once you start playing around with it, then I think it becomes very difficult. What he said, it's a very ethical area. I mean, because you're basically going to say to some patients, you're 44 and less, you basically are not going to be eligible for a transplant anytime soon. I think it's a very difficult conversation to have. Yeah, it's my thoughts.
No? If there is no questions, I will ask Professor Ho about the DCLO. You mentioned DCLO. You try to mention that DCLO is a better parameter for the respiratory problems in patient compared with the PO2. But as I read, actually the DCLO is not much mentioned. So how is that? How it's not so famous, maybe because the technique is difficult or because of what? Because in most article about HPS, they mention about the PO2 as a parameter. And the second for the Professor Gulnara, I really impressed with your presentation about the individualized care for the cirrhotic patient. I really wish someday I will have that kind of care in my clinic, which is of course very difficult. My question, the cirrhotic patient have a lot of problems like cardiomyopathy and a lot of pulmonary problems. Do you also work together with or you do that screens in all cirrhotic patients first? You send your patient to the cardiologist, you send your patient to the pulmonologist, you send your patient to the nutritionist at the first time, or can you explain it to me? Thank you.
I guess I'll start the first part of it, at least. So you're right in that there has been a lot of focus on the AA gradient and on PaO2. And the reason for that is, as I said, it goes back historically, back even to the 80s, where it was recognized that, if you had severe hypoxemia, those patients don't do very well. And even in 2003, it was based upon that large study that was done, it showed that, that many of these patients with a PO2 of less than 50, and obviously very high shunt fraction, didn't do well. But of course, I think that is now, and as I talked in my talk here, it's being challenged by new developments, obviously in ICU care, and that's probably why many of these patients do, considerably better than they did back in the past. So over the last 10 years, there's been significant improvements there. DLCO, you're right, hasn't really been focused. There's not been the focus so much in HPS. But if we know about DLCO, we do use it quite a lot. I mean, respiratory physicians use it a lot in many different conditions. For example, in interstitial lung disease, any sort of restrictive lung disease, DLCO is used a lot. And in my talk, I kind of drew that sort of analogy, I suppose, to what's happening in the lungs. You've got some of those fibrotic changes that is happening in the lung. That is stuff that takes a long time to remodel. The architecture takes some time to remodel after transplant. If it was just a tone issue, then it would, straight away after transplant, you'd see improvements. But many of these patients take a year or so or more to get better. And so we think there's architectural remodeling that is happening after transplant. So maybe that's some of that fibrotic stuff, which contributing to a low DLCO afterwards, it hangs around. The oxygen improves, the hypoxemia improves after transplant, but we know there's these fibrotic changes that happen afterwards. And it's interesting because you mentioned in your talk about mycophenolate mofetil and about the fact that it has all these properties, including anti-fibrogenic properties, which I looked at. And maybe some of those changes may be the reason why it could work in that one case report. Obviously, you've got to get more data. But you see, I think the analogy here is that in many of these patients that go for transplant, they've often got a lot of changes in their lungs, like collagen deposition, fibrogenesis happening, and that, I think, is the reason why you often get a DLCO which persists afterwards. But I'll give it to Professor Gulnara now.
Thank you. Yes, of course. Our department placed in the big multidisciplinary hospital, and we work with our patients in team, with specialists, cardiologists, hematologists, endocrinologists, and of course, and pulmonologists, because it's depend of the situation, because you know that liver cirrhosis is associated with many comorbid conditions, and as a result, only consilium or only a team system can help such patients, because in easy cases we can prescribe something for improving situation, but in serious condition we should use the specialist in this area. So
I'll ask a question of you, Dr. Gulnara. So I really like the whole list of things that you put down, like almost like a checklist. How do you make sure that you tick off, all the individual bits when you see a patient? Do you use it in a checklist format?
we use this checklist in each visit of patients and keep it in their cases. And so in any times, maybe 5 years later, we can check each visit and each condition on this day. So it's very helpful for next our steps for this patient. Yeah, and we prepare by ourselves. This is our. Okay, thank you.
Okay. Yeah, Dr. Nasir from Indonesia.
Thank you. Thank you for Professor. Maybe are there any special condition that we must prepare before a liver transplant is performed for the better result of HPS? Thank you.
Okay. Yeah. So you're saying what are the special considerations before transplantation? Yeah, so I think you do the usual. You would do the usual pre-transplant workup. So obviously, you do your whole set of. You take your history examination, your blood tests. You do your other additional investigations, including echocardiography. In specific for HPS, you would want to do, and what Dr. Liraga mentioned before, the key tests, whether it's contrast-based echocardiography or the macro-aggregated shunt fraction. I think in a way that's very important to sort of assess the presence of these intrapulmonary vascular dilatations. And then, of course, you're going to be doing some of those tests, the arterial oxygen tests on breathing room air, sitting upright. So that helps you delineate whether they're severe or very severe. I think that's important in terms of stratifying it. And then I think as part of your pre-transplant workup, obviously you want to have that discussion with the patient about what they might expect. So that's always part of the transplant workup, what you would expect after transplantation, what do you expect whilst they're waiting for transplant? What's the reasonable, if they ask you a question about survival, you should have a frank discussion with the patient and family.
Other questions? It is the last question. Yeah, please.
Yes. Yes, Gautam, thank you for the comprehensive presentation. I just want to know about, is there any early sign for the hepatopulmonary syndrome before the decreasing of the PO2, before there's a hypoxemia? Is there any sign for early detection for the hepatopulmonary syndrome?
Yeah, in our clinical findings that found that there are several clinical subsets have been found in some cirrhotic patients like spider nevi, clubbing fingers, spider angioma, cyanotic patient. So I think the first sign to you that if patient cirrhotic with clubbing fingers, it is PP positive value, it is more than 70%. I think it is clubbing finger is the best clinical features. And the other one, it is orthodexia, flatopnea. it is decrease of oxygen from supine to sitting up. It is maybe the other consideration when the patient with cirrhotic have orthodoxia. It is, I think, the clinical sign to inside for oxygenation examination.
Okay, thank you.
I think it is the last question. We applause for all the speakers. Thank you very much for your attention.